was a great talk, Janna. I really appreciated that. It set the nice tone for what we're going to be talking about now. Women's health has been facing a lot of challenges, whether it's regional nuances, societal dynamics, gender bias. We're gonna cover a lot of these things today. We also want to make sure you understand that women are the cornerstone of the community, and yet their role gets in the way of them taking care of their health. And that is causing a lot of issues today. So what I want to also do is we brought some experts to the table here. We're going to be asking questions. And this is a session where we're not going to have a lot of facts on the screens, because we want to make sure that you listen to them and the things that they're saying and the experiences, because they're on the front lines right now dealing with this issue and really being great advocates. And they represent research, clinical, advocacy, technology, a lot of great things that all combine together in an ecosystem to really deal with women's health. So, and I haven't even used my clicker, sorry about that. So we have lots of data, facts, but we're going to talk about that. You don't need to mess with that. We're going to also talk about how we can find ways to improve opportunities, working across providers, policymakers, patients, as in citizens, everyone. But really our goal today is to comprehend, the current state. We have representatives here and online from US and Africa and India. Now, obviously, this is a global issue, but we're going to focus on that today, and we'll continue. We also want to talk about accessibility, women's community roles that I just mentioned before, and also digital platforms and how they can enable better care. So, since I am not going to do anyone justice on introducing themselves, I'm going to have the leaders here introduce themselves, their name and their role, and maybe their passion about women's health. I'm going to start with you, Irene.
Good afternoon. My name is Irene Aninye. I'm the Chief Science Officer at the Society for Women's Health Research. We are a national nonprofit that's committed to advancing women's health through science, policy, and education. And we're based in Washington, D.C. The work that we do there is really promoting research on biological sex differences in health and disease, and focusing on women's health conditions or conditions that disproportionately or differently affect women, as well as exclusively affect women. So while a lot of times we think about women's health from the perspective of like reproduction or menopause or maternal health, we also have historically focused on conditions like Alzheimer's disease and pain, chronic pain, or autoimmune conditions that have a disproportionate impact on women's health as well.
I'm Janna Guinen with the Health Foundation, and the work that we do covers health equity broadly, but also specifically around gender equity for women and gender minorities, as well as diversity, equity, inclusion, and well-being of the healthcare workforce, which is in large part women.
And Mond-Johnson, and you all met me before with the ATA, and at this session, I'm going to touch on some of the work that we're doing on using telehealth to eliminate healthcare disparities.
Good afternoon, everyone. I'm Admiral Aisha Mix. I serve as Chief Nurse for the United States Public Health Service, but also Chief Nurse for the nation. And understanding that over 86% of nurses in the United States are women, we can understand clearly the intersect with this topic. And so it's something that I not only live and breathe, but I experience it personally. And so for me, the passion is understanding this parity, this equity that's needed when it comes to women's health, because it directly influences and impacts the nursing workforce as well.
Awesome, great. Let's have the leaders on the phone or on the online introduce themselves. How about Mevish? Could you start us?
Hi, Nicole. Good afternoon, good evening. This is Mevish Vaishnav. I'm the Group Chief Operating Officer at Digital Health Associates. We have 4 verticals: Health Parliament, which leads into policy and research, Digital Health Academy, Global Digital Health Summit, and Patients Union. Our major focus is on women's health. We have developed Women's Health Guideline, which is global. We are also working on Women's Health app. We have also launched the Women for Digital Health campaign. Thank you.
Great. And Esther?
Good afternoon, everyone. My name is Esther Ruiter. I am a midwife by training with a master's in public health, currently working for the Coalition for Women's Health in Africa, with a unified platform to combine private and public sector to create unified goals and work together to find sustainable solutions for women's health and enable the environment. With 10 years of experience clinically in sub-Saharan Africa, both public and private sector, knowledgeable about health systems. So very excited to be on this panel, and thank you for having me.
Great. Okay, so now let's get down to it. Let's talk some questions here, right? What are the critical, I'm going to start with you, Irene. We're going to start with the US first, and then we're going to expand into India and Africa. But what are the critical factors contributing to the complexities in women's health today?
I think one of the, I would start off by saying it's very unfortunate that when we talk about women's health, it often ends itself in being a political conversation as opposed to a people-focused conversation. And that is one of the greatest challenges, because we just have to understand what is going on in the body. And when I mentioned earlier that SWHR really promotes the research on biological sex differences, it's because if you look at a condition like Alzheimer's disease, it affects 2 to 1 women to men. And so if you do not approach the research and the investigation from looking at those differences, you will never be able to unlock what is going on with this condition, because there are clearly differences that are naturally occurring in the body. And then we also know that there's social determinants of health, and there's other sociocultural factors that impact the disparities we see in women. But we really have to bear down and look at that. And in historically, in the US, I mean, I want to say historically, but it's really 30, 40 years ago. So it wasn't even that far off. Women were actively excluded from being included in clinical trials. And it was to protect the, if childbearing years, it was in order to protect the baby. And so there now has to be a shifting, a reshift, and a paradigm shift in looking at balancing protection of baby and protection of mom. We saw this, for example, with the COVID vaccine, and COVID, of course, was not good, but one of the benefits when the vaccine came out, women, pregnant and lactating women, weren't included in clinical trials in the earlier stages. And so when the vaccine was available, we had absolutely no idea what it would do and how it could help. And it left women very vulnerable. And it now was on a larger scale where it was tangible to a broader population. And so we really have to make sure that we are focusing our efforts when we look at health and disease and seeing what are the differences between men and women. Why, for certain drugs, do they metabolize different in the female body versus in the male body? And these are very real questions. They're complicated, but we have to put forth the effort and the strategy to be able to identify these answers and investigations. If not, we are leaving more than half our population very vulnerable.
Aisha, can you add to that?
Sure, and I can also add to that, also from a federal and a national perspective as well. As we heard previously, right, in the United States, the rate of maternal mortality and morbidity is unacceptable and has been for quite some time. Almost 700 women die each year in the United States from pregnancy-related complications. And that's not even considering the almost 25,000 women who experience pregnancy-related complications. One of the things to note is that many of these complications and the women who lose their lives are in hospitals, right? And so when you consider the amount of resources that we have in this country in particular, many of us are dumbfounded in understanding what's going on. However, what I say, and it's something that President Biden, Vice President Harris have really taken on and created this blueprint. And when a blueprint is created from our White House, that means that all of our agencies are charged with doing something, right? So when we look at this blueprint and when we look at what needs to happen to the point of a paradigm shift, the first thing is listen to women, right? And this is a theme that we've heard all day long. right? And it's not a novel approach. It's not even difficult. You just have to choose to do it, right? So listen to women and make sure that women are actually a part of the decision-making that impacts their care. The second is looking at our services, making sure that they're accessible, making sure that they are quality services, right? And not that you set it up down the street, but that you bring it to where people can actually use it. And this is critically important, especially in our rural areas. The third is looking at our workforce. We absolutely have to diversify the workforce, but even more than what we tend to think of when we talk about a diverse workforce, we have to understand that in the United States, our model, our medical model that is physician-based and relies on medicine is not the complete picture when we talk about women's health, and especially when we talk about perinatal health. We have to understand the roles of nurses, of midwives, of doulas, of community workers. Everyone has a role when it comes to women's health, and again, especially health surrounding before, during, and after pregnancy. The other aspect comes to data, which is another theme that we've heard all day, right, and yesterday. Understanding transparency in data, understanding how to incentivize sharing of data to make sure that not only your positive outcomes, but the negative outcomes are shared, not from a punitive standpoint, but so we can learn and do things better. So projects such as those that are coming out of our Centers for Medicare and Medicaid Services, right, that actually identify the hospital systems that are following a collaborative model to improve pregnancy-related outcomes. Incentivizing, creating payment models that support high-quality care so that women and their families can actually make informed choices and hopefully have better outcomes. And then the last piece of this is actually understanding all of those wraparound and support services, including behavioral health services that are needed before, during, and after, right? And not just immediately after in the days that you're in a hospital setting, but when you're home, because that's actually when it's even more critical. So I think that we have a model, right? We have policy in the United States that supports it. Where we go wrong is relying on the things that we know haven't worked. And you know what they say about doing the same thing and expecting something different, right? So there comes a time where, you know, we've created a blueprint, right, from the federal government level, but it's going to take more than the federal government in order to make this happen. So I think that's at least a start, and to have the support, the funding behind it, but we need more. We need people to actually believe it and take it to heart and actually be in action.
Wow. That's, well, let's take that thought to Africa. Esther, would you like to share what's going on with the complexities there?
Yeah, thank you. And that's a tough one to follow, Aisha. I 100% agree. And there's so much to resonate also in Africa with system and model blueprints. But as a midwife myself, I would like to talk a little bit more about the maternal mortality ratio in Africa itself as well, to put it in perspective. And as you said, globally, and this is numbers from 2020, because data is like not following fast enough, but about 800 women die from preventable causes related to pregnancy and childbirth every day. That means a death every 2 minutes, which is preventable. And in the last 20 years, the maternal mortality ratio globally has dropped with more than 34%, which is great. But even though that is happening, more than 70% of all maternal deaths occur in sub-Saharan Africa. And to put the numbers on it, it's like sub-Saharan Africa has about 536 deaths per 100,000 live births, compared to 12 per 100,000 live births in high-income countries. And even within sub-Saharan Africa, we keep saying sub-Saharan Africa, there is this differences. Like Kenya, for example, has about 530 deaths per 100,000 live births. South Africa has 127, and Nigeria about 800 per 100,000 live births. And that's alarming. And if we look at the skilled health professionals attending these births, we've increased, it's amazing. We've gone from, in the year 2000, from 38% of all births being attended by health professionals to 69 in 2022, which is great. But the maternal mortality ratio has decreased, but not in a way that you would expect based on the skilled health attendance. And as a midwife myself, I think I resonate with it, because what we always say, skilled health personnel, And there's so many factors, right, that contribute to quality of maternal services, resources, infrastructure, health system, but also, as you said, Aisha, the workforce, the health workforce, and giving them the skills they need. I always ask the question, what is the difference between a skilled healthcare professional and a midwife? What is the training baseline what are their specialized skills that they need to be called a skilled birth attendant? And I think this is something where digital health can help immensely by really having the right access for the workforce to increase their skills to make sure that they can give quality care and reduce maternal mortality rates. And it's a very different landscape, of course, Africa compared to high-income countries. But I think there is definitely similarities in all these problems, to access to increasing skills, to access for communities to get to the health workforce. And that's trust. Trust is so important to increase. And I think increasing the skills in the health workforce globally, of course, will create better trust. So yeah, that's from me to add.
Thank you. And Mevish, can you share more about India?
Thank you, Nicole. Before I start, I would like to share what our Honorable Prime Minister, Mr. Narendra Modi, this year just announced for women, 33% reservation in Parliament, which means that we will have to see more women in position and power to decide for themselves. This is a major boost for women. This will also have a long-term impact in the healthcare, as we will see more policies and guidelines which will be developed by women for women. I would also like to state we have 1 million accredited social health activists, which are women. They are trained. So women play a very important role in healthcare in India, you see. The healthcare delivery system is done by women. And that is why I would also like to highlight the major success that we achieved, the milestone of bringing down the maternal mortality rate to 97 per lakh live birth in 2018 to 20 from 130 per lakh live births, which was in 2014 to 2016. But yes, there is a lack of awareness, which is very low. So we need to sensitize about the schemes that the government is building and which is there. Thank you.
Thank you.
Can I add something, Nicole, for
Sure.
just a moment? I'm thinking about what you said, Aisha, about having a blueprint and what we need to do differently. And I want to tell a story about a woman I met last week. She's a physician, Dr. Bio Curry-Winchell. She was having her second child, and she had had a good delivery the first time through, although a C-section. And she was in for her with labor and she was in for C-section with her second child. Everything went fine. She came out, she was in recovery, and she didn't feel right. And she said to the nurse, "I don't feel right, something's wrong." And the nurse reassured her, "This is normal, post C-section, post-delivery, you're okay." But as a physician, she knew better. And as a person, as a woman who had given birth before, who had had a C-section before, she knew better. And so she said to her husband, "I'm terrified, something's wrong." And only then did the doctor come, because he insisted, and she was bleeding internally and could have died. And so what I want to say today is something very simple about what needs to be changed. And it's something you mentioned, it's listening and believing. And I think it should be part of physician, nurse, community health worker training, that when any patient, a woman or anyone says, "Something's wrong," let's do something right then and there, rather than just being reassuring as a part of training, which is very well intended. So I think it's a really important, very, very simple thing that could change in medical training and would have an impact on outcomes.
Great ad. That's great. Okay. So let's, gonna keep this going. How can we ensure equitable access to healthcare for women? I'm going to point this back to you, Irene.
For equitable access, you have to take, we consider a very three-prong approach. where we engage providers, policymakers, and patients and patient advocates. And oftentimes, the healthcare system is deformed because there's either a lack of resources that can be seen at the provider level, and resources to implement care, but then also resources as far as training and understanding of various conditions. There is disparities that we know exist, biological disparities, those social determinants of health that impact women, but then there's also access issues and coverage for healthcare. And so at the patient level, at the provider level, and at the policymaker level, we really have to learn to work together because everyone has their own expertise, and that's great. And they're thinking down their focused area, but you really have to bring them together. And so a lot of the work that we've done is looking at these interdisciplinary networks to address these problems, because the provider, like you mentioned, there's certain set of training that they have, whether you're, for example, as we mentioned, nurses, midwives, OBGYNs, all have a different type of training that they receive. So their vantage point is very different. And so they're thinking about the health outcomes, they're thinking about, the clinical aspect. Well, the policymaker is looking at the money. They're looking at the constituents. They're looking at a lot of numbers and data, but the patients are looking at me as an individual or my family member or my loved one or that community worker if they're a patient advocate. And so we have to bring those perspectives together. It helps to balance out. It helps to address those complex or those grand challenge issues that is only seen unilaterally in one perspective, that now when we bring them together, our working groups were able to address more of the complex issues and look at it from that 360 perspective. What education needs to happen? Who needs to come to the table? Do we need to go to the professional societies and make sure that they are heralding, a new technique or innovations or clinical guidelines? Do we need more, patients or those that are in leadership to be at the table, women to be at the table when these decisions are being made, to remind them of the outcomes or the challenges that actually exist in the system when implementing, right? And then the various interventions, if a policymaker doesn't see what's going on, if they don't get that data, oftentimes they don't realize that the system is not working. They know it's not working, but they don't know how and where it's breaking down. And so they can't really do anything without that data. And I know we're talking about data and digital, but I also want to drop in a pin that data is more than numbers. Like you mentioned, the story, that in every woman's story, it is archetypal of a lot of other women's stories. And so that qualitative data is also very important. And I know we love numbers, but even the story of one is representative of the story of many, and that we have to make sure that they are also brought to the table with all the other numerical data that we have.
Well spoken. And on that note, maybe, so Irene was talking about the framework that they have done their work on. You've done a lot with ATA. Can you share what you've been doing with Access?
Sure, happy to. So about 2 years ago, during the height of the pandemic and following the George Floyd murder, we convened an advisory group that still meets monthly, and the group was focused on how we can use telehealth to eliminate disparities. And the first product of that group, the first output, was a framework to consider. And it had different layers that needed to be examined as we work through this really significant problem. And I put it out there because women are, there's obvious disparities that we've all touched on as well here. So I think it has application. At the top of the pyramid was the issue of connectivity. And we put that at the top very deliberately because, number one, it is obvious. And number two, we heard enough feedback from folks who were in positions to change things from a regulatory or legislative perspective to say that we had heard them say that if we just get broadband everywhere, we're going to be fine. And that couldn't be further from the truth. So we put that at the top. Beneath that was the issue of access and affordability. And by that, we meant the access to devices, the access to internet and broadband, the affordability of the data plan, and so forth. And this was also very important. The third layer that we identified had to do with literacy, and it was touched on earlier, the whole notion of health versus digital literacy. And they go hand in hand, the fact that people often just don't understand. And it's not because they're not intelligent, it's because, back to the user experience, we do a horrible job of explaining things in healthcare. And there were several other layers, but I would say one of the foundational ones that I think affects communities that have been discriminated against or have not received adequate services, both women and Black communities, communities of color, rural populations, is an issue of trust. And our society obviously has become increasingly polarized, at least in the US. Our trust element in traditional institutions has eroded as well. So trust is a big factor. And then last week, the group released a interactive map that I encourage you to look at americantelemed.org. And this map put together and conveyed a digital infrastructure index that you can look at that's created by 4 components. And they include upload and download speeds of connectivity. It includes access to devices. It includes 2 other factors. The point being that the score itself varies dramatically by zip code across the United States. And it varies within counties. So for example, you can have 60611, which is a fairly affluent community in Chicago, and then just travel not very far west and hit communities where the digital infrastructure score is quite low. So in some instances, it's very reminiscent of the redlining that has occurred in the United States as it relates to housing. But what was also important about this map was that we said the interventions need to be evaluated using an economic social value score. And it's a calculator that looks at the components that can be improved and puts it in terms of value added to the community. And I would submit to you, it's a completely different framework. It's a riff on ROI, return on investment, but I would say it's a different mindset that we have to adopt, because the economic value associated with having a healthy mom, who is oftentimes 76% of the decisions made in healthcare for her family are made by the chief medical officer or the mother. And having a healthy mom available to her family, there is a value added to that that is not obvious in one point in time. And if we continue to rely on ROI, at least within the United States, as we evaluate our investments, we're going to continue to have problems. So it's really, you know, we're ignoring half the population in the US, and it's not to our advantage.
Thank you. I appreciate that. Aisha, I'm going to kick it over to you, and you can share your experiences with this subject.
Sure. And I think, you know, a number of things actually come to mind here. And I think it's important to understand that, you know, I know for me and many, we focus a lot on maternal health, but we have to understand that the impact on maternal health is directly related to the health of a woman before she becomes pregnant. And I think that the larger conversation of women's health, we have to remember that not every woman chooses to become pregnant or chooses to have children. And anytime that we can make sure to elevate the conversation also, right, to understand that women are not only important, or women's health is not only important when the person becomes pregnant or becomes ill, and an understanding that we actually have to address the needs of women throughout the lifespan, right? And so I think when you talk about access, it is making sure that we understand, you know, what programs, what policies we have in place, and how they impact, whether positively or negatively, impact the health of women and the ability for women to access the services that might be available. One of the examples that I use often is identifying and understanding, if you plot out and you map services in a community and you understand that you have the correct number of providers per capita, right? You have all kinds of services all along the healthcare continuum, but then you recognize that the hours of operation are from 9 a.m. to 5 p.m. So as I said, even in situations such as those, you may have the best services and the best providers, but for many women especially, those hours just do not work, right? And that's no matter if she's taking care of herself or taking care of a family. Oftentimes, even those things are overlooked in understanding access to care and the ability to access quality healthcare services. I think the other thing that's important to understand when we talk about access, because as we've said many times, even on this panel, it's not good enough to have access if it's not quality, right? So how can we make sure that the providers who are in communities that are most underserved actually have access to training, knowledge, information that is available elsewhere, right? So in areas for us in the federal government, for example, within the Indian Health Service, which is a large population in this country, a very large underserved population, a very large rural population. It's establishing partnerships with organizations such as the American College of Obstetricians and Gynecologists, the Association of Women's Health Obstetric and Neonatal Nurses, the American College of Nurse Midwives, the American Academy of Pediatrics, who actually have a partnership with IHS to provide consultative services to make sure that the knowledge is actually provided for those who are serving in these areas, because it's not as simple as just send more, right? You have to actually make sure that you strengthen what you have. So I think it really is taking an honest look at each community and understanding what that community needs, figuring out how to remove those barriers, because really that's what's in the way. Because if you ask a woman what she needs, she will tell you. You have to be ready to do something about it.
There's something about that women's intuition of something's wrong, just like the story you shared. And yeah, that's great. Esther, we're going to have you answer this question as it relates to what you're doing in Africa today.
Yeah, and I think what I'm to introduce with the Coalition for Women's Health in Africa, we're really trying to connect the private and public healthcare environment to make sure that we work together towards the enabling environment. And to recap a few things that were said, like Anne said again, the trust is so important for people to be able to go to the healthcare facilities or go to the healthcare workers. Then the quality healthcare for us, as Aisha said again as well, the quality needs to be up to date to make sure that, again, we can trust to go to the healthcare facility. And I'm gonna put my healthcare worker hat on for a second. So as I said, to increase the effectiveness of healthcare and to make sure that people access this, we need to have quality healthcare, health workforce. And as more than 70% of the healthcare workforce is women, we need to skill these people. And I think private-public partnerships to really increase digital education for healthcare providers is crucial. And I'm going to talk from my experience now as well, because me as a midwife, trying to keep up to date with the continuous training that we as healthcare providers need to do, I struggle here being not able always to do in-person trainings. Like even here in Kenya, the Nursing Midwife Council told me that I should go back to my country to make sure that I get the right skills. But that should not be the case. If this is how we're going to act towards skilling the health workforce, we're having a problem. And that's why I'm saying digital tools for these trainings are crucial. But we also need to have an enabling environment from the government out to make sure that we don't have policy vacuum and to have a landscape for digital solutions in women's health to be developed. Because currently we have lots of different apps. There's an app for nurses, there's an app for this, and there's an app for that. But if we don't harmonize these apps, we have fragmented education. And again, that brings me to the baseline of what are the skills for what position. And there is that saying, right? Use the right tool for the right job. skill the right healthcare professional with the right tools to make sure that they can provide us access, that people have access to the right quality care. And I think, I mean, obviously I'm talking here for more on the African continent, and there's definitely, like, I've practiced in Europe as well, and there's much more of the skills already available and there, but like we're one step behind here, and we're talking about people accessing healthcare professionals, but are they equipped with quality care or the skills? Not yet. And I think we need to take a step back here and make sure that we really educate our workforce properly so that trust can grow and the quality healthcare workforce can grow. So that's yeah, I think very important to take in consideration when making these new policies globally, but also regional specific.
Thank you, Esther. We'll take some question and answers at the end, if that's all right. So the next question is, we talked about access. We talked about all the challenges that are faced today and some of the great work that's being done through either government programs by creating these frameworks. But let's talk about digital platforms and data and technology and how that can enable and empower women to improve their own health. And I'm going to kick it over to Anne on this one.
Well, I can say that in the United States in particular, and probably in Europe as well to a certain extent, what we refer to as femtech is going to be a nearly $50 billion market within the next few years. And this is a sector that's evolved rather quickly. It's attracted a fair amount of capital, so there's a level of innovation because of the unmet needs of 50% of the population. And so we had sort of some raunchy conversations in our preparation for this panel. Well, not raunchy, it was transparent, let's just say. And you look at some of the variation that occurs around reimbursement for services for men versus services for women, or medication for men or medication for women. I don't think I could be much more pointed than that. And so these platforms really make it much more transparent for women to get the care they need, to feel like they can trust the source that they're getting the care from, that they can rely on it. And I just think that those are very, very useful. I don't think it solves the problem of the disparities. I don't think it reaches enough people, but it really, it is a tip of the iceberg sort of solution, if you will, or approach.
Great. So Mevish, we're gonna talk about all the great things that you're doing in India. Can you share some of the Women's Health Guide and things that you're doing to help educate women?
Thanks, Nicole. I would like to take this from Aisha's point. We need to look beyond the reproductive aspect of women's health and focus on their holistic health by adopting an approach that covers all the stages of life, being from fetus to birth, to infancy, to childhood, youth, middle age, and old age. So we have developed this guideline, which is actually a global guideline. It's a women's health guideline. This was developed under the guidelines of the top clinicians for the use of end users, which is women. So we have a ready reckoner in this where you can see symptoms is given on based on that symptom. I don't know if you're able to see it. So listing of symptoms has been done, issues women face in different stages. According to that, screenings, what they have to do according to the symptoms and what action a woman needs to take. So if my mom is of 50 years old, she wants to know what test she needs to do at her age for osteoporosis. She can just look into this, see what symptoms she is facing. Is it the same? Do she need to consult the doctor, or she needs to do some exercises? It is given in that. So this is one thing that we have done. And by the end of this year, we are also launching the Women's Health app, which will actually be covering the health and security of a woman. So like Esther said, that we should have an app which has a comprehensive thing, We have different apps. For period tracking, it's different. For water tracking, it's different. So we are getting a holistic app where you'll get everything together. We also need to have women at leadership positions. So we are trying to get more and more women in the leadership roles in digital health. As you know, during the starting of the career, healthcare is the domain where more women in the young age start getting into that career. But as they reach to the mid-level, they start dropping. So we need to mentor them, support them, and guide them so that they reach to the leadership position roles. We have also launched the mission scale, where we are supporting the startups, women entrepreneurs, so that they can meet the funders and get support in that. So these are the things that we are doing in India from Health Parliament.
Great, thank you, Mevish. Sure.
Add a comment / question, I guess, with one of the complexities about women's health, and it was mentioned, I think, in the last session, is caregiving. And so women are providing informal caregiving for someone in their home, oftentimes, or a parent or something. And so when it comes to digital platforms, and I can speak to this even from personal experience, it's very important to consider how caregivers are accessing the digital platforms and data of the person that they're providing care for, because it's usually their logins and things. But as a caregiver, can they participate in the telehealth? How can they do this third-party work? And so that's something that I think is also needs to be taken into consideration when looking at women's health in the digital platforms.
And allowing the caregivers to have the access to help their loved ones.
Yes.
Because that personal experience, that's a tough thing. So with that in mind, I'm going to actually ask you, Janna, to talk about what you were talking about, Tequity and Femtech before, but wondering if you can share anything else that you've been finding throughout your research.
Well, I want to say a little bit about how we can solve women's health problems through digital health. And I'm going to first start with what you said, and that's around caregiving. Women do globally bear the burden of caregiving for children and for family. And I too am experiencing this for the second time now. I think that women are motivated to take care of themselves as well as others. And if there is a way that digital can make it efficient for them to do the both together, to perhaps incentivize their health and the health of those that they care for together in one very efficient and convenient manner, I can't tell you personally how helpful I would find that. Honestly, there's very little time when you're caring for others to care for yourself. So what can the incentives look like? I also think that we have personalization at our fingertips when it comes to digital because of the great wealth of data that can be collected. So we could personalize apps for women, absolutely, depending upon their language, their caregiving role, their purchasing power, which we're well aware of, but somehow venture capital is not entirely caught up with that. 50% of humanity, but 3.3% of financing going to women founders, which is a personal passion of mine. So I think that personalization is another way that we can go, and we really must go. If I'm given an app, if you're given an app, if it's not really appropriate to my lifestyle, I can't tell you how many apps I have on my phone that I don't use anymore. Why? They just didn't speak to me. They didn't really fit my time, my style of managing my life. So these are things that Tequity can address. So that's what Tequity really means. It means finding those things that really speak to each particular patient and using, again, that great wealth of data and computing that we have at our fingertips to ensure that each person has a solution that will help them to self-manage. I don't know anybody who doesn't care about their health. So we're doing something wrong if people aren't caring for their health as well as they could be.
Great, thank you. So the last question before we hopefully have some questions from the audience. Well, if you could change one thing or put a focus on one aspect of women's health that would give ultimate rewards immediately, what would you focus on? I'm going to go through the line Here, sorry. Okay, I just threw a little wrench in the plan there. Okay, well, we'll go this way because I've been picking on Irene, so we'll go with Aisha.
I thought I dodged it, and then we came all the way on this side. One thing, really, it brings me full circle to what I started with. Listen to women, right? And even just those 3 words, if each of us can take that, own it, and figure out how you can do a better job, because I offer and submit that even as women, we also need to listen to women, right? Because one woman's story is one woman's story. And so we also have to be open to listening to each other in order to make sure that the needs are actually incorporated into the work that we're doing. So I think that that would be the one thing, if I could change it, I would have everyone walk around with that mantra and to wear those glasses so that they see every encounter through that perspective and really trying to figure out how can I be intentional about listening to this woman. And that's in the healthcare arena, that's in the business sector, that is wherever you come in contact with women in your life. And I assure you that even that small action actually has an opportunity to have tremendous outcomes and benefit.
I'm gonna go to you, Ann.
I'll go a little bit out on a limb because you're so much better than I am. It's true. I would say a gentle reminder to all of us, the economic value and benefit of investing in women, the huge difference it made when women were able to make choices about whether or not they would have children and when they would have children, the benefit of having them really be able to have their own business or produce their own livelihood. It's no mystery why organizations focus on women when it comes to economic development and support, and we should adopt the same approach when it comes to healthcare. The value is enormous.
Janna?
I'm going to focus on one little segment of what you said, Anne, and that is women in entrepreneurship. There's so much value that comes out of funding women, and yet they get so little of the funding. And I also know, just from my experience working alongside the Health Inc. team and previous experience, that many of the founders that are currently underrepresented, women and others, when it comes to getting financing as startup founders, they are not exposed to the same kinds of education. Venture capitalists will say they're often not prepared for the pitch. I think there are also differences in gender-based differences in leadership style, in presentation style, and a whole lot of other factors that play into the low financing that women tend to get as entrepreneurs. But I believe highly in starting on entrepreneurship at a young age. So I would put an entrepreneurship program in every high school, in every university, and every adult education program in this country. And I would make sure that women have access to those, and that they can start developing and growing their ideas and seeing themselves as entrepreneurs from a young age.
If you can indulge the educator in me and just participate. So I'm gonna ask, when you hear women's health, just shout out what comes to mind. I'm hearing different conditions, diseases, and things of that nature. If I said the health of women, what would you think about? Health of women. Global. Shifting the mindset would be the thing I would say. Instead of looking at a specific disease, a specific issue, think about the health of women and focus back on making sure that you want them to thrive as an individual and as a person and not just fix a particular issue.
Very nicely done. I'm going to go online. We got to make sure that Esther and Mevish get to share their thoughts as well. Let's start with Esther.
Yeah, I'm going to go with the proper collection and representation of gender-specific data. Make sure that that's there. It's not just listening to women qualitatively, but also quantitatively, to make sure that we can really show what the economic value is and what the health needs are and the health platform is needed for women. It will also increase entrepreneurship. So I'm combining them all, but gender-specific data is so crucial, and we've not been doing this enough because women do have different health needs than men, and we have different biomarkers, and that just needs to be acknowledged. So for me, to make sure that we have the right data in our hands to apply the right solutions would be crucial, and I would really like to prioritize that.
Great. Mevish?
I think we actually cannot prioritize only one thing in health. It is everything or nothing. So health is actually multidimensional. So if you want to focus something, woman has to keep herself first, not the family, not the children, but herself first. If she is healthy, family is healthy, and the nation is healthy. So we need to look as a comprehensive approach.
Very nicely put. Great. All right, so we can open it up now to questions and answer. I think we had a question. Yeah.
Hi, really inspirational conversation, but this is my observation. In Wales, out of 7, 8 organisations running health and social care, 6 chief executives were female. The UK has had a female prime minister even, right? It has made no difference to the equitable access of healthcare for women. Part of the conversation is about talking to women about the importance of this to women. And I think that you need to probably rethink the problem, because there was no better opportunity for women's healthcare to be prioritised when most of the decision makers were actually women running an organisation.
Can I speak to that one? If you look at studies of how and when corporations perform better with diversity, it's not just when you have representation. You can bring a whole bunch of women to the table. If you do not have inclusion, so a culture and a policy and a mindset of making them equally available or equally invited to speak their minds, then we'll have the same problems that we always did. So that's one thing. And I will say these studies show that for companies who invest in both diversity, representation, and inclusion, the top quartile of those companies really outperform on the bottom quartile by profitability, innovativeness, and several other measures that really matter, competitiveness that really matter to companies. So, but the other thing is the surrounding society. So, depending on the roles those women are in, they may not be able to influence the change. And so that, in a way, is the classic glass cliff story where a woman is hired. I think of Roz Brewer, very sadly, about Walgreens, that she was one, I think, was she the only Black woman, Fortune 500, female in a Fortune 500 who was recently moved on, AKA potentially let go. I am not really sure which, but it looks like a glass cliff scenario, because when you set a woman up and say, well, we could really, we're in, right? We're in on diversity. We're going to put women at the table. If you don't change everything around her, or at least be willing to listen really hard to things you may not want to hear, you're going to still end up with the same result.
Thank you. Well, thank you to all of you for this nice discussion. So I really appreciate. So my question is related to connection and communication. I do agree that having women at the high levels is very important, super important. And then the question is, how do you visualize the connection with the natural leaders that are in each of the communities? Because of course, you were asking also over those places that are disfavored economically, but we know that there are some networks already working there, and there are some natural leaders, and sometimes they have also their traditional medicine there. So how the communication is going there? How do you visualize the connection between these different leaders and the hospitals and the official institutions and not the official institutions? So how can you see this? Thank you.
So I can take that one first. And I think, what you've mentioned is spot on. right? And so in the conversation and really, kind of piggybacking off of what we were just talking about, the difference between diversity and inclusion and equity, right? So those, having women in high-level positions is phenomenal. It's necessary, it's needed. That doesn't take away the requirement that we still must engage with the community to understand what the community needs. And in many communities, there are people who we call gatekeepers. And these are the people who actually know the pulse of the community that we're looking to serve. And without engaging the community gatekeeper, you will not get into the community to understand what's going on. And in different communities, it looks different, to your point, right? And so it takes having an understanding of the community that you're trying to impact, bringing the community to have a seat at the table with you, not after you've met and present your product, but no, have a seat at the table with you to be a part of the discussion and designing what you hope will impact that community. So I think what your point is actually accurate, and we also have to do a better job of reaching into those same communities in order to develop our providers, no matter what title we call them, because it will look different based on the community. And so engaging and making sure that our educational systems educate providers and understand what partnership looks like regardless of your credentials.
Fantastic. So the great thing about organizing events is that you can step in when you want to. So, okay, Cara, about 3 years ago, I guess, and we don't set out to do events, but the ECHAlliance does a lot of events. And Carolina said to me that I had to make sure if I was involved in a program that we had at least 50% women participating as presenters. And I said to her, yeah, but I just want good people. I don't care what color, creed, I just want talent. But this is a fantastic panel. And when we decided this was a topic that we wanted to address, you've exceeded my expectations. Now, there's a question coming from me, okay? But first, what I want to say, and I'm going to challenge what Phil's just said, okay? I wanted to sit in on this panel when I first thought about it. And then I thought, no, it's got to be women. But Phil's point is interesting because I had that conversation with Irene lunchtime where I didn't understand, because actually in the NHS, at the senior leadership in the department, there are so many women. And I could not understand why women aren't doing things. And then Irene put me right as to why, and I go, okay, I get some of that. But here's the challenge for all of the men in the room. Okay, because this doesn't change until we change. And by we change, what I mean is, I have a mother. Most men have sisters. Most men have daughters. Why the hell wouldn't we be interested in seeing women's health improve? Like we are connected, we are incentivized to do this. So we have to be part of the change. We have to be prepared to stand up and talk and fight for women's health services, equity, whether we're talking access. So for all of the men in the room, for the ECHAlliance, we want to actually promote this. This is important, this discussion. So that's an action from our point of view. We will keep this agenda at the front. We will keep having and engaging in these conversations. And the question that's coming, okay, is you've again diagnosed lots of the problems. But what we've been trying to do yesterday and today is to say, so what's the call to action? What can we do after today to actually drive this agenda forward? So I'd like each of you just to think for a second. What do you think we should be doing? All of you should be doing. What can the ECHAlliance facilitate to actually make positive progress?
To answer that question, I will piggyback on what Aisha said. Identifying those gatekeepers for whatever area that you want to affect change, because it's interesting, you can make a woman a CEO, but does she have the influence? Although she has the position or the title, she may not have the influence. And so wherever you are, identify who has the influence and bring them to the table early. And kind of what you said, not after you've made the decision and say, here, take it to your people and share our agenda. They need to be at the table. And that way you have not just the leadership, but then you have those who also have the influence rallying towards improving change.
I would say that, you know, to your point earlier, Aisha, we've created a blueprint for you, and it's up to you and us to fill it in. So one thing I've invested in a lot is mentorship through C-Sweetener and through other organizations. I think it's really giving opportunities to women to say, I'm going to model the behavior that I wish had been given to me. I'm going to invest in businesses because no man invested in mine. But revenge is sweet, right? So there you go. Have a nice exit. So, but that's the sort of thing I think that for me personally, and I think to the extent that ECHAlliance wants to embrace or partner along any of these dimensions, it would be most welcome.
I would say continue to encourage the hard conversations, right? Because it's easy to have these conversations with people who agree, right? We had a fine time engaging and preparing for this panel. Why? Because we all agree that it's important. We don't need to convince each other, you know? And so it's critical that we have places and spaces, and I'm glad that it was safe enough for the question to come to the table, because that is a valid question. And we have to be open to hearing these challenges, because it's not as simple, you know, to just, you know, make it happen. If we had magic wands, we wouldn't be in this situation to begin with. So we have to understand what's in the way for people in different places and spaces. We have to hear from people who say, I tried what you told me, it did not work, right? So we have to figure out, well, then what's in the way in that circumstance so that we can help inform it. And I think through, you know, groups and networking and engagement such as this, we can create those environments where these conversations can come to the table so people can go back and be armed with something to do it even better.
And I'm not sure if online can also add to something like that. And I think it's also, again, piggybacking, but partnership and collaboration, and exactly what ECHAlliance is doing as well. What we as the coalition are doing, what I'm just saying is building each other up instead of saying that didn't work, she didn't make it. Why didn't it work? Can we talk about it? How can we help that person to grow and make it actually happen? Have that system in place to make sure that we can achieve the goals. And it's not one person, it's not one woman, it's not one leader that is causing a fail of an issue. It's a collaboration and partnerships. And I think that's exactly what we need to keep doing.
Thank you. May I still jump in? I'm being shown that we are running out of time, but just thinking also about the like what we can do, and as a person passionate about this and also promoting this issue within the ECHAlliance, I'm also thinking that we all have to really spread the message and raise the awareness about the issue and the gender bias. I remember I also told Bleden this 2 years ago, and I read a book about the gender bias, and then I was shocked that to discover that so many clinical trials were conducted without the participation of women. And what we think that aspirin is good to prevent heart attack, it's good for men, but apparently for women it actually works. Like it might be worse for women, it might actually harm us, but we don't know about it. And actually this is also undiscovered issue. It's pretty silent, like we are only learning about this. And of course, women don't participate in clinical trials, but for many different reasons, because they might be in the age that maybe this is not something that they should do, and so on and so forth. So I think that for me, for example, my commitment is also to help raising the awareness of this issue, and I think we will continue with this discussion and with these hard conversations. Because we agree, but then the rest of the world does not know even that this is an issue. And I see that John still wants to jump in.
I just want to be so bold, and it's largely because we've got someone from the Surgeon General's office, so sorry to pick on you, Aisha. And I'm just going to float a balloon as an idea. It would be a tangible thing to do, it would strike me, to take some disease state, for example, that disproportionately affects women, endometritis, for example, and say we should broaden all the CPT codes we need underneath that. It's 58662, it's the only one that's there, it's undiagnosed largely by male doctors. Wouldn't it be a wonderful thing to go and take that on, track the process of turning that into 10 separate codes to manage it. So that's 10 million people in the US alone. It's a 9-year length disease that goes undiagnosed. If you could do that and use it as a poster child, I think you might just find you have a pathway for change in women's health. What do you think?
Yeah, and what I would say is absolutely. I completely agree. And I think that at the same time, we have to have all that goes along with it, right? Because in order to have that diagnosis and that code, you actually have to be able to see a provider, right? So I think it's a bigger picture, but I think to your point, you know, within the bigger picture, there's always a simple solution, right? So then there's a simple solution and there's a conversation of what's in the way of making it happen to actually connect to the outcomes we want to see. And that's the part that we tend to miss, we being the federal government especially, because it sounds like a great idea until you start to try and figure out how to personalize it across multiple communities. And that's where things tend to fall apart, if you will. So I absolutely agree. And then what I would say, as was mentioned by my colleagues, then how do we get women diagnosed? Because that's the other side of it, even after we have codes.
Can I just make a quick note? Endometriosis, I'm glad you brought that up. About 2 or 3 years ago, it wasn't even a tracked disease on the NIH's website. So if you don't even pay attention or track, and 10 million women have it, 1 in 10 women have it, it wasn't even trackable.
Yeah, and can I add then that just generally, to answer your question, Glenn,
Look what you've done.
we all jumping in here. Well, I think we all, I'm going to go back to something I said earlier in my presentation, which is that discrimination is something we all suffer from. And you can't know in many ways. We have unconscious bias in so many different ways. So can we just commit to and become comfortable with the idea that it's there and then make policy? Can we just make a policy within ECHAlliance? Great. You're going to have 70% at least. You're going to have 70% women on all your panels going forward. Thanks for committing to that. No, but what I'm saying is it's so simple. You know, it's are we really committed to seeing it through? You know, it's got to be written in stone somewhere.
I'm sorry, but we're going to have to wrap it up. And this, I can't tell you, I would feel so blessed to be with these women and all the leadership qualities and where the conversation went today. It wasn't, I put a little timeline and it just didn't really, but this is way better. And I hope we get the band back together because I feel like we need an anthem coming in when we, you know, there's a song of some sort. But thank you so much. I know, Ann, you got to hit the road, and thank you so much for your time and your effort online. Everyone's wonderful.
Being a great
Thank you.
Moderator.
Absolutely.
Thank you.
Thank you.
Thank you very much, Nicole.
Thank you.